So how do you typically then diagnose epilepsy or treat it in your practice?
Just like any other neurological condition, history is very important. And as we were talking about, the structural reasons can cause seizure. Even if somebody had only one seizure, we have to get the MRI with the special cut, which we call a coronal flare, to look for any kind of scarring in the brain. There are people, they had febrile seizures, has increased risk of having seizures in the future. So we look for the temporal lobe, which is a common seizure focus, to see any structural abnormality there, and also other developmental anomalies. So we definitely need an MRI of the brain with and without contrast. And then we do electroencephalogram or EEG. The routine EEG is done 20 to 30 minutes recording. And if you don't see anything in that EEG, that doesn't mean there is no increased risk of seizure, because EEG is a measure of the brainwave activity at the time we do it. If we are lucky, we may find something called interictal discharges. Even if you don't see seizure, you may be able to see the spike where it is coming from. That tells us where the seizure focus is. In certain people, we don't even see that at all, because at the time we record it, there's nothing going on. So we have to do an extended EEG. We do have the opportunity to do an ambulatory video EEG. The scalp electrodes we put on them, they go home, typically for 72 hours, because if somebody had a recent seizure, if we do a 72-hour EEG, there's almost 96% we are able to pick up the abnormality. Especially it's read by an epileptologist, which is a specialist, treat the epilepsy. And we had the ambulatory EEG or long-term EEG in the hospital. It's similar, but it is concurrently monitored. That could be also normal. Then you go with the history. Patient has a stereotypical episodes. Based on your expertise, you have to decide to treat them. In certain cases, we even have to do more invasive, like a stereo EEG, to detect, okay, is this episodes are actual seizures or not? Because we want to exclude other conditions like a syncope, passing out. Those are all could mimic a seizure. We do not want to treat those conditions as seizures. So to diagnose and to exclude other conditions, we do these MRI EEGs.